Continue with the international aspect of the program. I'm pleased to introduce Professor Elko de Koning, who will be our first speaker of the day. Elko is professor of diabetology at Leiden University Medical Center, a group with which we have a longstanding collaboration, mostly through Marlene Kuhneman, who you met and heard yesterday. He obtained his medical degree from University of Utrecht and is a board certified endocrinologist. He obtained his PhD working in the diabetes research laboratories at Oxford and was a visiting scientist at the Joslin Diabetes Center in Boston. He coordinates the National Islet Transplantation Program and the Modi Expertise Center in the Netherlands. His main focus is to improve care for patients with type 1 diabetes, with research focused on a better understanding of human islet biology in the transplant context and of the patient perspective. And Elko will be talking to us about experiences of making care fit, both in practice and in research. Please join me in welcoming Elko de Koning.
Thank you, Victor, for this introduction, and thank you for having me. And thanks for all the nice conversation that I have with several of you and here at the unit. It's very inspiring and see the great work that's going on. So my talk will really be kind of disease focused, but I'll try to focus on some aspects and also personal experiences that I have with a group of patients with very complicated type 1 diabetes and the struggles that I have myself to find together with the patients the right treatment options for those groups, for this group of patients. And I'll get you through this presentation. These are my disclosures. But I'd like to start out just where I come from. So it's the University of Leiden. Leiden is kind of between Amsterdam and The Hague. It's actually the oldest university. It was given by William of Orange to the people of the city of Leiden because they resisted the Spanish in the 80-year-old war. Basically, they did that by just flooding the countryside, so the Spanish had to retreat. Well, and then we got the university in return. It's quite a good deal, I think. Leiden is also known for something else, perhaps you know or you may not know, but it was actually home of the Pilgrims for quite some time. At the time, also when Rembrandt was born. So when you go to Leiden, there's a American Pilgrim Museum. There's a whole pilgrim tour through Leiden. And the pilgrims stay there before they move to England and then straight to Plymouth on the east side of the US. And we even have a Hotel Mayflower in Leiden, so if you want to stay there. So this was the introduction in Leiden. So what I'll do is I'll start discussing a little bit, setting the clinical scene of type 1 diabetes. Just all kind of clinical aspects. So we know the impact of the disease on these patients, also with regard to mental aspect, and then going into some aspects of care and how to make the right decisions for those patients that have very complicated type 1 diabetes. So it's now more than 100 years ago that insulin was discovered. And here you see the newspaper clipping, Toronto doctors on track of diabetes cure. But of course, it is not a cure. It is a symptomatic treatment. And actually, since the discovery of insulin, well, more than 100 years ago, there has not been actually a big change in treatment, right? It's still insulin. And the insulin is delivered in another way, and there's more technology involved, but it's still insulin. It's still symptomatic. And the problem is that the insulin-producing cells are destroyed in the islets of Langerhans. And these insulin-producing cells are vital for life and for metabolism. And what we actually try to do in clinical practice is that we try to mimic the cells as well as possible with the technology that we have. So measuring the cells measure glucose and secrete exactly the right amount of insulin. And basically, we take over that by measuring the glucose with our glucose measurement devices and providing insulin with injections or pumps. And as I said, technology has been a real revolution in technology. So you see now most of our patients with type 1 diabetes now have some form of continuous glucose monitoring. But actually, technology also has another aspect of additional burden of type 1 diabetes, basically technology burden. So it has many benefits, but it has also burden, and I'll discuss those aspects. And the way this advance in technology has come about is that we now have systems where a glucose sensor is actually talking to a glucose pump through algorithms. We have now the so-called hybrid closed loop systems. And actually, the patient hardly has to do anything anymore apart from making a meal announcement, so that at least the system can try to prevent a very high glucose peak. So this is hybrid. But where we're going to is bihormonal, fully closed loop systems, where the patient actually doesn't need to actually put in a meal announcement anymore. Basically, the system could completely take over. And this is kind of a technological advancement that many people are looking to. On the other hand, what we see is that type 1 diabetes has always been about self-management, right? It's about everything that you do in your life has effect on glucose levels. Actually, you know, people say there's about 40 factors that influence your glucose homeostasis. And people have, what we do in education is that we try to teach people how these factors can influence their glucose metabolism and how can they deal with it by changing sports, changing insulin administration. So basically doing self-management. The problem also what we see with these hybrid closed loop systems is the patients also become dependent upon the system. And that once something fails, that suddenly there is much more unease, much more distress, because the self-management actually was taken over by the system and now they have to go back again. So there's been a lot of changes in the life of patients with the technology, a lot of good, but also a lot of challenges. And the challenge, I think, still is this kind of trying to maneuver between the two extremes of glucose metabolism, which is too little insulin with high glucose level and risk for long-term complications. That's what patients are worried about. Some patients really want to have only very low glucose levels because they have in the back of their head that there's complications. But also that if there's too much insulin with the risk of hypoglycemia and the risk for collapse or even accidents or death, and the fear of hyperglycemia. So there's different fears that play an important role. And the important thing is that we as a diabetes team and healthcare professionals, you know, we need to work together in order to reduce this diabetes distress as much as possible and positively reinforce patients in the way they deal with their diabetes and give them advice. Because of course there is, if you have long-term hyperglycemia, there is complications, you know, both the eye, the kidney, the heart, the brain. So this is something that is just a fact of life. But we also know that if you improve your glucose level, that you can reduce this risk. And that is also why many patients, well, they want to have a good glucose control, but it is difficult. It is difficult to achieve that. It requires a lot of work. And what you also see is that over time, the level, and I think this is also what Marleen showed, this is a slide that Marleen showed yesterday, that in different time periods of a life, you see that it is more difficult to achieve this self-management. And here, for example, you see the HbA1c as a measure of glucose control. And what you see in the dashed line, that is generally considered a level of glycemic control, which should be the target, 7%. But if you look actually at, this is among more than 48,000 people in the US, in different centers. if you look at the level of below 7% that the people reach in 2016, 17, it was 20%. And in 2021, 22, which is the blue line, now is 26%. So that means that still 3/4 do not achieve their target levels and are at a risk of developing those complications. Even though in 2022, many people already had those advanced technology systems. So these glucose monitors in 78%, pump in 62%, and this modern hybrid closed loop system in 33%. So despite the use of technology, there are still issues. And what we also know, and especially for the young people that you see here, is that the higher your glucose, the average glucose levels, so your HbA1c, there's also a risk for hospitalizations. And this also has a major impact usually in the life of patients when they are hospitalized with diabetic ketoacidosis. And the peak prevalence of hospital admissions is about 17, 18 years. In women, actually 12% in this study from England and Wales. So, so again, different time periods in your life, different life phases have a different impact and different risks. And that is also why with Marleen and Anka, we focus especially on this young type 1 diabetes group, where there's such an improvement to be achieved. And despite so everything that we do, the mortality in type 1 diabetes is high. And I think this is an aspect that perhaps over time with better care of our diabetes teams, that with better control, it becomes less. But it's still like 3 to 10-fold increased compared to patients without diabetes. So the loss of life expectancy is about 11 to 13 years. So this is the kind of clinical setting that face patients. And many of my patients also, they know this, they realize this, and sometimes that also puts a high mental burden on those patients. And this is a psychosocial burden. So the prevalence of comorbidity, mental aspects, depression, eating disorders, anxiety, and reduction of quality of life really in this group is very high. If you look at the, for example, also established relationship, especially those with very poor glycemic control, and that I see that are referred to us in the entire, for the Netherlands, there's actually a lot of those psychosocial issues that need to be dealt with. So when you think of it and you say, okay, there's no technological cure, then what can we actually do to cure type 1 diabetes? Because the only real solution is actually when those patients get new insulin-producing cells. This is the work that I do in the Netherlands. So I get referred patients from all over the Netherlands where the diabetes team and the patient actually feel that they are with their back against the wall because of complications, because of the impact of diabetes, where they say, well, with more advanced technology, we're not going to improve quality of life. And what kind of other options are there to perhaps do a transplantation? And so there are two types of transplantation. You can transplant the entire pancreas, but it's a big procedure, a big surgical intervention with also mortality, with increased mortality in the first year. But of course, there's also the prospect of having a functional cure. For many people who've been suffering from diabetes for decades, the prospect of a functional cure is enormous. And that is something that we also need to deal with in a subtle way, and I come back to that. Another way of perhaps providing an improvement in glycemic control is not to transplant the entire pancreas, which is a big procedure, but to isolate the insulin-producing cells and then give a cell transplantation. So these are the two options, although in the US at the moment, this is not reimbursed. So in the US, only pancreas transplantation is possible. So I am working as a endocrinologist, but for 50% in the transplant center and for 50% in the endocrinology unit. So I see all the patients that are referred for pancreas or islet transplantation, and the patients from students to very old patients with type 1 diabetes that are on pumps or CGM or closed loop systems in the center. And I just give you two cases because it shows what kind of options there are, and that if you have severely complicated diabetes, what are the options, and how in an unbiased way can we discuss those options with the patient. So this is a patient, male, 49 years old, type 1 diabetes since age 5. He always had very poor glycemic control, and since 5 years it was better with an insulin pump and a Freestyle Libre. So that's a small glucose monitor. He had none of those severe hypoglycemic events, but he had all kinds of complications. So he had eye disease, and he had end-stage kidney disease, and he received a living donor kidney transplantation 9 months earlier. And he was referred for information on further treatment options. So what are the treatment options? And then you can say, okay, we continue with the insulin delivery. But if you continue with the insulin delivery, of course, not much will change, perhaps a little bit better glycemic control. At least in the Netherlands, we could go for islets, but I'm not going to that now because we cannot do that. Or there's the pancreas transplantation. And there it is a cure, but a high procedure risk. And it's not like there's the choice between drug A or drug B for treating hypertension, right? It is a cure, a potential cure. And how do you discuss this with the patient? By also discussing the risk that there is an increased mortality in the first few years. On the other hand, these patients have had this chronic disease for decades, and there's a reason that they were referred to this center, because they were with their back against the wall. And in my experience, sometimes I have the feeling that patients, when I talk to them, that they only hear functional cure and they do not hear the potential risks. And the problem is, if that happens and there's all kinds of risk of taking lifelong immunosuppression with all the side effects, that they get disappointed by the treatment. And if they get disappointed by the treatment, then I always feel that if people are disappointed by the treatment, that there is something that I missed in the shared decision-making process before, right? Because then the expectations were not right. And especially when it's kind of just minor change or improvement, continuing on insulin or a functional cure, I think that is it's an important topic, at least for this group of patients. The interesting thing is when you look at could there be some guidance from from decision trees, for example, or from what the field thinks about these patients. So if you look at this patient, for example, who had the living donor kidney, so here in the middle. So then you look at, okay, what factors do now determine what could be the right treatment option. So then we look here in the red square and we see problematic hyperglycemia, progressing diabetes complications, adequate kidney function, low morbidity, obesity. But it's all kind of health-related factors. If you look at how many life-related factors are actually mentioned in this kind of decision tree, you see one thing is patient choice. It's kind of very vague. Although for having a good balance in life, life-related factors are so important in some of the decision making, but still here it's all health-related factors. And I'm actually a co-author of this paper, so this needs to be revised. There must be much more emphasis on these life-related factors. So the second case is a female, 43 years old. She had type 1 diabetes at the age of 9. And her main problem is she has very unstable glycemic control. She doesn't feel her hypos coming. So they could just arise. despite the fact that she has a hybrid closed-loop system. She had one severe hypoglycemic event in the past year, where a third part, it was actually in a shop. So she collapsed in a shop, and an ambulance needed to come. And usually also these events have a huge impact on patients. She had problems with the stomach, so that also made her her glucose be more variable. But she had good kidney function, and her physician actually referred her because she had such a high disease burden, and she was referred for further information. Now, this patient does not have an organ transplant. She doesn't use already long-term immunosuppression. So if we think about some really vital aspects, it's not only that, again, for this patient, there could be a functional cure and a high procedure risk, but also we need to make the decision that she would have lifelong immunosuppression. If you already need a kidney, you already have the immunosuppression. So then it's not an issue anymore, an additional issue anymore. But here, the additional issue is lifelong immunosuppression with all its side effects of development of cancer, development of severe infection. And again, here, sometimes I have the feeling that people, even though you stress this fact, but that it's difficult to have a kind of an unbiased. And perhaps because I am working at Transplant Center, I have already my own bias of being more towards a transplant option than continuing automated insulin delivery. So what we did is we actually thought, what I also showed you in this decision tree, that there is a scarcity of life-related factors that probably are relevant in order to make, together with the patient, the right decisions. So what we started to do already 10 years ago is that we did screening of all our patients, a psychological screen. There's two groups we grouped the patients into two. So in the middle column, it says SPK, PAK, IAK. So these are transplant candidates with kidney failure. So they either go for combined kidney pancreas or pancreas alone or islet alone, or pancreas after kidney or islet after kidney. And then the other group are PTA and ITA. So these are patients with all these hypoglycemic events and really a very high disease burden. And what you see is when you look at the unemployment rate in this latter group, 70% of the patients are unemployed. And in this other group, it's 57%. HbA1c is very high, so about 8% in the kidney failure group and 9.5% in the other group. And also the use of antidepressants is high. The diabetes distress is high, using the problem areas in diabetes questionnaire. And a score above 40 is really considered to be associated with clinically relevant diabetes distress. And also the, is really very sensitive. And the emotional well-being with 60% is also especially low in this group with very fluctuating glucose level. At least it's an attempt to get more insight into psychological issues. Because in the end, in my view, for patients with type 1 diabetes, what they're trying to do is lead a nice life and remain healthy. And leading a nice life means that you can fulfill your life-related goals, at the same time trying to achieve as well as possible your health-related goals. And there should be a balance. If there's a disbalance, it adds to diabetes burden and diabetes distress. So how to get more handle on this life-related factors? So now I'll go to some personal experiences. Because in 2008, I was asked to be an expedition physician for a group of type 1 diabetes people that wanted to climb Kilimanjaro. And the idea was that there was a foundation, the Bas van der Goor Foundation, that promotes exercise and that promotes that people with type 1 diabetes can have ambitious goals. Because many people who have with type 1 diabetes who got a diagnosis at an early age, many of them were always said, well, perhaps you should hold back a little bit with those big challenges. And actually the foundation wants to show, yes, but you can achieve those goals with the right help from people and with the right coaching. So that's what we did. So with a group of 8 patients with type 1 diabetes, we climbed Kilimanjaro, and it was actually a very emotional experience for quite a lot of people that always thought that because of their type 1 diabetes, they would never be able to do such to achieve such a challenge. So this is one thing that I learned from this group. Apart from that, it's great to walk among the giraffes and the zebras onto Kilimanjaro. Of course, this is kind of a separate thing. And I wrote in 2008 for the Dutch Journal of Medicine. I wrote a column about my experiences as an endocrinologist taking care of patients with type 1 diabetes. And I wrote, since many years, I check HbA1c values, check blood glucose values in diaries. That was still the time that people had to write up their glucose values in diaries that they took to their physician, and check weight. But only now I realize how important it is to experience what happens in their daily life. And of course, 2 weeks Kilimanjaro is not really daily life, but we also had kind of training programs and a lot of activities in the in the half year before that, where you really get to know patients. And when you are in a tent and you hear all the alarms going off of the CGM during the night, you also understand the kind of burden of technology that many of those patients face. So since then, I am a volunteer for this foundation about every year or every 2 years, basically, coaching groups of patients with type 1 diabetes to achieve these kind of goals. So it could be mountain climbing, but it could also be cross-country skiing. And I learned a lot as a doctor. I learned so much from being with those people for a longer time about how that there is no cooking book regarding how you do a 90-kilometer cross-country run in Sweden. That for every person you need kind of an individual strategy. That sometimes circumstances make good preparation difficult. You may have trained for a year on how to manage your glucose values early morning, but when you have to leave in the bus at 3 o'clock and you arrive at 6, then suddenly everything is different. So you need a plan A, but you also need a plan B and a plan C. And there are patients, and you also hear the stories of patients. And one of the things that I also learned is that fear is one of the worst motivators there is. And still, I think that as physicians, we often talk about risk and fear, and you have a 20% risk of that in 10 years you're not there anymore. But it's usually a very bad motivating thing, motivating action. As I said, the burden of technology, of glucose sensors dropping off, or things not working, insulin pumps being blocked, and this actually happens quite often. So Marleen already said a little bit about the study that we do regarding a photo voice of patients, that they take pictures of their daily life, and how that could be perhaps helpful on how to approach them. I also feel that with those challenges, I'm also kind of a photo voice, but I get all kinds of glucose values from those patients and how they feel and whether they're satisfied with this. And this is just one guy with type 1 diabetes who decided his own challenge to cycle for 214 miles on a mountain bike in 1 day in Spain. And basically he sent me all his values. So you during the day, he said, okay, I took here 1.3 units of insulin, but I got a hypo. And it's basically started in the night. He finished in the night, and then he made it. And then you see here on the right side, he had a time in range, cycling for 214 miles. He had a time in range, so good glucose values of 90%, but he was not satisfied. I think it's fantastic, 90%. Yeah, I mean, even if people do not have diabetes, they reach like sometimes 90%, 95%. He was not satisfied. And I think the burden of technology is that before you did some finger pricks and you had some good glucose values and you were fine. And now people have 70%. And then next year they want to be at 80% and then 85 and 90. So, so we need to deal with also their own expectations of themselves. And sometimes people give marks. So these are some profiles. I'll not go into the details, but this was a lady. She's actually a diabetes specialist nurse who went on a large biking trip, but her glucose monitor didn't function anymore. So yeah, so her entire ride she experienced as really stressful, and she had to stop all the time to do finger pricks. So it's actually a photo voice of sports activities. But that can also be really helpful when I see those patients again. So in my view, what I've learned from all these expeditions over this past 16 years, and also in all the preparations and a lot of weekends that we are together, is that in fact life-related factors is what motivates most people to guide self-management, and not so much health-related factors. And the steering for fear of complication is not a good motivation, and the burden of technology can be considerable. So there's no technological cure. And perhaps this is the most important thing: the time in range is not time in happiness. So after this, I became chairman of a committee in the Netherlands to aid doctor-patient interaction in primary and secondary care. And this was organized and sponsored by the Dutch Diabetes Federation. And basically the focus of this committee was that life-related factors should be more a topic of communication in consultations with doctors in primary or secondary care. So it's a stepwise approach where in step one we discuss the factor that influence treatment, that influence goals, treatment options, and professional support with the patients. And many of those life-related factors, could be discussed. Doesn't have to be always that everything needs to be discussed, but it should be a major part of consultation. Of course, also health-related factors. Then in step two, it is about setting the personal and health-related goals. And this is what I just said. It's the balance between life-related and health-related goals. Step three is discussing the treatment options to reach those goals. And step four is assessing the professional support based on those goals and on the treatment options. And then this could be an iterative process. And we consultation model, and we have like consultation in the Netherlands. It's about 30 minutes during the yearly review checkup. And what we did is we trained healthcare professionals in several hospitals on aspects that they're not usually so familiar with, also regarding, for example, illness perception, preferences. The patients prepared the yearly review, and then with questions: do you have a health problem? Do you wish to find a solution for this during the next consultation? How would you like to solve them? And what additional support do you need? So this was before the yearly review. And then they had the consultation, and then we provided questionnaires to the patients and to the healthcare professionals afterwards. So it was 74 physicians, 31 nurses, 6 hospitals, and all patients, were above 18. And we published this in Diabetes Care. So basically, it was supported by the Dutch Diabetes Federation, trying to kind of have these life-related factors more into the consultation. And in general, according to the diabetes care providers, there was largely decision in 80% thought there was largely a shared decision. And if we ask the patients, then about 94% of the patients at least indicated that they thought that shared decisions were an important aspect of this consultation, and also that the life-related factors determined for a major part their treatment goals and the options that they chose to achieve those. So, and these, together with another PhD student, in this trial, we looked at what, according to healthcare provider, were kind of out of 20 factors, what they thought were the most important ones. And the 3 top ones were quality of life, motivation, and self-management skills. So not over glycemic control or complications of diabetes or comorbidity. So, well, at least with training into this consultation model, at least in this trial, and I think that Annie yesterday already said, I'm not sure if Annie is here anymore, but how difficult sometimes these trials are in several centers. And we never went back to see, the maintenance of this. We never looked at, but at least in this study, we could kind of make some initial steps, and it's still being promoted by the Dutch Diabetes Federation. So also based on actually how Victor, perhaps, or some discussion with Victor. When we talk about translational medicine, it's often that people say, well, it's from the bench to the bedside and back. But in my view, translational medicine is also from home and to the outpatient clinic, from the living room to the outpatient room. That is also translational medicine. And I think we could focus much more on that part of translational medicine. So what we did in our clinic, where we have in the diabetes team, endocrinologists and diabetes specialist nurses and dietitians and medical psychologists, is that we all together thought, well, how can we optimize shared decision making? Because what we actually found out when we, with the outside agency, we got help, was that there was a lot of overlap in what the dietitian does and tells patients, and what the diabetes specialist nurse does and tells patients, and what doctors patients, and that could be much more integrated, where we all know how to work with this. And what we also try to do within the clinic, it's called, I'm not sure whether this is proper English word, I call it flip thinking. And flip thinking is that, I think in the old days, we look at HbA1c. So the first thing when you enter a room is, what is your HbA1c? What is your time in range, right? And then you look at and then from that, how can you get that better? And then only after that is the psychosocial barriers, and then perhaps a personal goal is kind of at the end of the consultation. But the flip thinking is that it should be the other way around, right? It should be, what is your personal goal? And what are barriers? And wait, that's here, yeah. So it should be personal goals and the context in which self-care takes place. What are the barriers in order to achieve those personal goals? And then which part of self-care is difficult? And once we, in my view, once we look at it from that way, then ultimately, without discussing HbA1c, but HbA1c in the end is a reflection just of everything that you have done before. So how can barriers be removed? How can diabetes self-care in steps with concrete feasible goals be optimized, and that will have a positive outcome without actually discussing it? So we never discuss HbA1c. So we said we're never going to discuss kind of HbA1c primarily. We're never going to discuss kind of a percentage weight reduction or a risk. We discuss the goals, and we discuss the barriers to achieve those goals primarily. So also in our electronic health record, we also said that if it is goals, it must be very concrete goals. like a weight reduction of 20% is not a concrete goal. An HbA1c improvement of 0.5% is not a, what can a patient do with that? But if you say, well, your glucose are high in the afternoon because, you're sitting at work all the time, then perhaps, if you say, well, perhaps I can move around a little bit more in the afternoon, that is a concrete goal. So always, and we try with the entire team, we always try to do a concrete goal. The dietitian and the diabetes specialist nurse and the doctor, they all see what is those concrete goals, how were they formulated in the previous consultation, and how is it now? Okay, so shifting gear, because I think that I told you about the transplantation field, and there's a lot of movement in the transplantation field, and I think this is going to affect in the future the potential curative options for patients with type 1 diabetes. I'll just give you a small flavor of this. So what happens, for those of you who have followed the field a little bit, or this kind of general scientific field, is that we now have so-called pluripotent stem cells around. And these pluripotent stem cells are cells that kind of keep on renewing, and you can make like an unlimited number of those cells. And these cells can also differentiate into every cell of the body. And over the past 25, 30 years, there have been a lot of developments into generating insulin producing cells out of these cells. And diabetes is at the forefront of these developments in regenerative medicine. So, and why diabetes? Because you only need one cell type. You only need an insulin producing cell, and this cell can measure glucose and secrete insulin. So, so it's an interesting field, together with Parkinson's disease, because you also need like one type of brain cell, and also retinal disease, because you again need only one side. It's much easier than generating an entire kidney in the laboratory. And so what we do is that in 30 days in the laboratory, we can generate from a pluripotent stem cell insulin positive cells that look exactly like the islet that you have in your body in the pancreas. And why I am mentioning this, because there's now clinical trials going on in patients with type 1 diabetes using these cells that have been generated in the laboratory. And this was in the New York Times. It's already a couple of years ago. This is one patient who was treated with these stem cell islets and was cured, basically. And last week in Madrid, the interim analysis of this trial was presented. And out of the 12 patients that were followed up with type 1 diabetes, 9 were cured. And so there's a lot of, well, movement and interest, and this will also, I think, if you look at all the blogs and patients, they notice that there will be treatments upcoming that can potentially cure diabetes. It may take a while, and the safety needs to be established of those cells, but it's going to change the landscape. And then it's going to change the landscape, and then we need to be ready for this. How do we then this? Because first it will be the patients with the most complicated diabetes. How do we make the decisions of, on the one hand, providing a functional cure for patients who have a high disease burden, who suffered from diabetes for such a long time, but with the risk of lifelong immunosuppression and some uncertainty about cell safety. And I think these are discussions that need to be done. So the last slides are actually about these decisions that you make with patients. And this is a quote that I always like, and it's from a book, The Undoing Project, but actually the quote is from Daniel Kahneman, who's a behavioral psychologist. And he says, people don't choose between things, they choose between description of things. And if you translate it to our patient group, it's not, they do not choose between option, but between description of options. And I'm very aware that that perhaps I have a biased description of options. How for this very complicated group, how we can do that better. Because the way we say it, like the 1 month survival rate is 95%, or there's a 5% mortality in the first month. I mean, what kind of different messages that give? No more diabetes in 20% after 5 years, or no more hypos in 100% after 5 years. I always find it difficult to do that. And patients, they are willing to accept a lot of risk. So we did a survey on procedures with so-called implants, with stem cell-derived islets in 850 patients. So what kind of risk are they willing to accept? And they could choose between implants that were as large as a coin, or as large as a €5 bill, and does the number of implants make a difference, or the number of repetitions? And basically, well, it's always difficult, or you have to give a lot of information. The patients are willing to take a lot of risk, and is that justified? When there is a functional cure, do they really realize this risk? And that's something, that we need to work on. So this is the kind of future of this patient group, that I think as long as immunosuppression, so this lifelong, drugs with severe side effects need to be given, probably the therapy will be for a very small group of patients. But I foresee that with the advancements in all kinds of biotechnology, that there will be cells that will not require immunosuppression. And then there will be a lot more patients potentially eligible for this treatment. And I think with regard to shared decision-making, make the right choices together with the patient, I think we need to be ready for this. So with this, I'd like to thank you for your attention. Happy to take them.
Very nice. Thank you for that wonderful presentation. We have probably about 8 minutes for questions. So please, if you're online, please use the Q&A function for that. And if you're in the room, please raise your hand and someone will run mics. Victor, can you run mic to people in the room? Perfect. Thank you. Yeah. Okay.
Do we need physical activity? Any questions, comments?
Thank you. Is it? Okay. First of all, thank you so much for that presentation. My name is Cristina Praño. I'm a physician from Ecuador, and I just joined the care unit as a researcher. So my question is, actually, there are 2 questions. The first one is, you said that setting, like, patients having personal goals should be at the top part of a funnel. What if the patients, they don't have a personal goal? Is that something that we also should address as a multidisciplinary thing to help the patients set a personal goal? And do you think that is going to help them with the control of their the treatment?
So the thing is, when a patient comes into my room, it's often I say, "How are you doing?" Now I don't ask for glucose values. I don't ask. I say, just, "How are you doing? What's happening in your life?" And some patients right away say, "My glucose is 10, or it's been 10," and they have over time they've been so focused on health-related issues that I have the feeling that they hardly have any space in their head to think about other aspects of their personal life. So in communication, I try to look at how they can also develop this personal goal, or at least express the personal. I think many have personal goals. Perhaps it's just the expression of those personal goals in consultations that is difficult. So yeah, so I think everyone has personal goals, right? Whatever it is, life-related goals. It's just that, especially in chronic disease, if patients are overwhelmed with their disease, it's just that it's not easily a topic of discussion. That may be due to me in the past or other healthcare professionals in the past. I think we play an important role in being open and having open communication so these personal goals can be told. But I think it is an important effort, because once you know those, then you know what I said in the funnel. You can identify the barriers and help with the barriers, and then improvement in diabetes distress and also in glycemic control will be kind of automatically generated because you worked on that. Yeah, that's my view.
One, I think there's another.
I have a quick question. Well, yes.
Thank you. So I was just going to ask, how do you approach the conversation of potential lifelong immunosuppression? I think that was kind of your main thought, was how hard are we selling that versus the risk profile of that? I'm just curious how you approach that conversation.
So it's so if in the approach of immunosuppression, it is a topic that I think when I speak to patients, and I see them back, and I've given all the information. Probably the topic of immunosuppression is in the end the reason why people do not choose for a transplant option. Perhaps my administrators at the hospital don't like me for that, because they cannot do a kind of a financial issue, but I think it's the right thing to do. So the problem is with immunosuppression, and especially with, for example, Facebook groups, is that often the negative aspects of immunosuppression are really kind of focused on. So I just try to give as many kind of data on what it exactly means to have certain immunosuppression. So the most common side effects, but also the ways we can still mitigate that or change immunosuppression. It's a fact that there is a specter of side effects and a risk of certain types of cancer and infections. That's the way it is. And I think if you're open about it, sometimes I always tell patients, if you say no now, it doesn't mean it is no forever. And sometimes they come back 2-3 years later and they say, I've tried to get my life, I've thought about it, but my quality of life or the way they express is so low. I want to go for the transplantation anyway, because I feel I do not improve. And then they're ready to accept the risk of immunosuppression. And then I think also there's not or less disappointment afterwards. I think if we transplant too easily, there's much more dissatisfaction afterwards. Yeah.
Thank you.
A couple quick questions. There's folks in the room that are part of patient groups online that provide support and guidance to other patients. And so you mentioned Facebook groups, maybe a comment or two about peer support. And then the other question is, do you think optimists get more treatment? In other words, if you are talking about all these terrible things that will happen, if some people just will go on and buy the lottery ticket because they will be the winners.
Yes.
What is the role of optimism and pessimism in getting diabetes technology?
Yeah. Well, I think it is, so Teresa, so your first question was related to peers. I think peers are really important in every aspect. I see that in with all these challenges, I often get the feedback, my healthcare professional was not useful. I had to find out myself or from a peer. And also in those Facebook groups, even though sometimes there is too much focus on a side effect that I think, well, this is not really realistic. But in general, through Facebook, patients get into contact or they get telephone numbers. And I think in general, it is helpful. Well, like this. And the second part is, yes, it does an optimist get a transplant earlier? I think somebody um, who is so focused on a functional cure, that is the most important thing in his or her life, and no insulin at all. Well, yes, perhaps if they express themselves in such a way that they have a very high disease burden and that this is the only thing that could kind of save their life, if you call that an optimist, yes, perhaps they do get that. But they could also be disappointing if that doesn't happen. And that's also what you see.
One more question and then we'll wrap up.
Yeah, hi, Dr. Howard Haft, University of Maryland School of Medicine. And first, I want to thank you for an incredible presentation, and your passion and your empathy and dedication really shines through all of this. But question is really looking at this work, which is really important through a lens of equity, and comparing it in the Netherlands to the US. Here in the US, there's obvious barriers that go beyond just the personal life ambitions that have to do with the legal status, insurance status, and other things. Are those issues that you have to deal with in the Netherlands, or is it more democratized there?
Yeah. So I think this is a really important issue. I think I was discussing yesterday about the treatment burden questionnaire, for example. And there's now also, in the original treatment burden questionnaire, there's no financial paragraph, right? And for the US, I think there's a financial paragraph. In the Netherlands, I mean, it's socialized medicine. So the costs are, there's no out-of-pocket cost. There's nothing. So it's not an issue. So that is a major difference. I think when also cost, at least for the patients, are relevant parts of the discussion. In none of my consultations I ever talk about cost, and the patient also not. Yeah.
Can't say socialized medicine.
Right?
Yes, we can. Yes, we can. I think we'll have to stop.
Thank you so much.